And in today's presentation, we're going to talk about sperm count, shrinkage, quote unquote, and fertility. So the main reason we're addressing these topics is there's, of course, the concern with patients on TRT that lifelong protocols will reduce the size of your testes, potentially impact your fertility, and suppress your HPTA, or your hypothalamic-pituitary-testicular axis. In short, this means your natural testosterone production will be impaired and potentially shut down altogether. While this may seem worrying or worrisome, we'll cover why this isn't something you need to be worried about if you're working with a progressive, experienced physician who is prescribing hormone optimization therapy. So let's go over the science behind why this even occurs. So your hypothalamus, this is kind of the master gland in your brain, secretes something called gonadotropin releasing hormone. And this causes the pituitary in turn to secrete luteinizing hormone and follicular stimulating hormone, or FSH. Now, the increase in these hormones causes the testes to stimulate the Leydig cells to produce testosterone via conversion of cholesterol. The produced testosterone then has the ability to undergo various metabolic processes, which will then inhibit gonadotropin releasing hormone, which will then turn inhibit the secretion of LH and FSH, which brings a halt to natural endogenous testosterone production. So this whole idea where testosterone goes ahead, acts on the hypothalamus to reduce GnRH, or gonadotropin releasing hormone, and then acts on the pituitary to release LH and FSH, is known as the negative feedback loop. So once testosterone has stopped being produced, it doesn't send this negative signal, and then GnRH starts back up again, starts acting on the pituitary, which then goes ahead and sends out LH and FSH, and then goes to the testicles, and they resume creating testosterone. Okay? So that's how it works in a situation where there's no exogenous or no injected testosterone, so a natural situation. So how does TRT affect this? Well, when you inject supplemental testosterone or exogenous testosterone, it introduces increased levels of testosterone in the system, obviously, right? And so the brain, in this particular point, the hypothalamus and the pituitary, sees this increase in testosterone and then shuts down the hormones that are required to produce testosterone from the Leydig cells in the testes, right? And so you can kind of see in the diagram how exogenous testosterone is a negative and is working a negative feedback loop on the hypothalamus and the pituitary gland, right? And in that vein, the gonadotropin releasing hormone and FSH and LSH are being decreased, right? And so when LH and FSH are secreted, so FSH works on Sertoli cells, which are important for spermatogenesis, and LH works on Leydig cells, which are important for intratesticular testosterone, right? Both of those processes are decreased, and in particular, sperm production is decreased, and that the term for that clinically is azoospermia. So again, because of this effect, one of the most common side effects of testosterone replacement therapy is low sperm count. What's kind of interesting is TRT was once thought to be a form of birth control, but because it is not 100% effective, that is, certain individuals do see a large decrease in sperm count, whereas others don't, it was never really pushed forward. There have been multiple scientific trials using various forms of TRT, and again, these trials have shown that Some men will develop pretty significant sperm count drops below 1 million. Other men may not, but there is a significant portion that do. And the key idea is intratesticular testosterone levels, or ITT, generally are they tend to drop, right, as you inject testosterone, right? And if your intratesticular levels are not high, your sperm projection drops, right? And the key way to kind of overt this, or trying to get around fertility, is to try to maintain high intratesticular testosterone levels. And so, this might be, and again, this might cause a lot of concern for individuals watching the presentation, like, oh, well, if I get on testosterone, I'll never have children. But the reality is that's not true. Because, again, it may be instructive to go back to the previous slide. You can see that intratesticular testosterone can be increased by supplementation of LH and FSH, right? And there are medications that we use that can boost this. And when you increase LH and you increase FSH by introducing them exogenously, they act on the Sertoli cells and the Leydig cells, and the Leydig cells will increase your intratesticular testosterone. The Sertoli cells will, of course, increase spermatogenesis. So let's talk about those things you can do. Okay. Before we get into that, it's important to note not all men are built equally, and so there isn't really a cookie cutter approach that'll work for everyone. And it's important to work with someone that takes because of this, it's important to work with someone that takes a pretty individualized approach that will try to work along your specific clinical situation. It's definitely possible. Just work with someone who understands how HCG and HMG works and is willing to prescribe that. So again, the primary medication prescribed by physicians to maintain fertility is HCG, or human chorionic gonadotropin. HCG it essentially replaces the luteinizing hormone that's produced by the pituitary. It's a mimic of LH, so it is the beta subunit of HCG is a pretty good mimic of LH, or luteinizing hormone. And you inject it subcutaneously to counteract the reduced LH secretion from the pituitary when you inject testosterone. And again, HCG will directly stimulate the Leydig cells to continue testosterone production and maintain high intratesticular testosterone levels, and thus drive sperm production, because high ITT levels, of course, have a positive effect on the Sertoli cells to produce more sperm. Now, HCG dosing protocols kind of vary from doctor to doctor. It can also vary based upon the individual's medical history and their tolerance to HCG. A common protocol that's used is a dosage of 100 to 500 IU per injection, and that's usually done a couple days in a row or every other day, and usually it's injected subcutaneously into the fat tissue of your lower stomach or the fat pad of your outer glute. This will also produce the testicles with an increase in size. You can, again, when you're on TRT, experience a decrease in the size or fullness of your testicles. So HCG can, by stimulating the Leydig cells, can overcome this to a certain extent. Of course, there are some side effects with HCG. It tends to elevate estradiol levels, and so this can cause estrogenic side effects, of course, such as water retention, mood disturbances, higher body fat percentages, and, of course, gynecomastia. Again, For most men, all that really is required to maintain spermatogenesis is HCG. Uh, and, and by most, I mean about 70 or so percent. And so in many cases, just being on this can maintain your fertility and improve it. In the event where you weren't on it with prior therapy. However, there is a segment of individuals that will need something to optimize their FSH, or follicle stimulating hormone. And what we do for these particular individuals is we utilize something called human menopausal gonadotropin. Additionally, we also use something called Clomid, which is a selective estrogen receptor modulator. So human menopausal gonadotropin, or HMG, is a pretty potent fertility medication which will increase sperm count, and it stimulates sperm motility in men because it mimics FSH, right? And it's stronger than HCG because it, in addition to mimicking FSH, it also, to a certain extent, mimics LH, right? And so thus it binds to receptors in the testicles that HCG alone cannot do, right? Remember that HMG is pretty expensive, whereas the SERMs, on the other hand, are more available. The SERMs typically do not need to be injected, whereas HMG does. And the most common SERM is Clomid, or clomiphene, and it acts primarily by inhibiting estrogen feedback in the hypothalamus and the pituitary. When you take away the estrogen feedback in the hypothalamus and the pituitary, that will increase the release of LH and FSH. So one of the benefits of using the SERMs versus using HCG alone is that you can also get the release of FSH, right? And so that's kind of interesting. And remember, there's a segment of the population, not every man, but there's a segment of the population that does need support to increase both FSH and LH, right? And may need HMG and HCG, or Clomid and HCG. Another medication that can serve a role are the aromatase inhibitors. So aromatase inhibitors, we use them primarily in TRT to reduce the conversion of testosterone to estrogen within the peripheral tissues. And because of this, remember, estrogen has negative feedback in addition to testosterone on the hypothalamus and the pituitary. And this, of course, if you reduce the amount of estrogen that can act on the hypothalamus and the pituitary, you'll also reduce the inhibitory effects it may have, and you can increase gonadotropin, FSH, and LH production. And I like this diagram because it kind of brings everything together. You can see how testosterone itself, right, will inhibit the pituitary to reduce FSH and LH, and inhibit the hypothalamus to reduce gonadotropin releasing hormone, right? And so exogenous testosterone will do the same thing. If you use a SERM like clomiphene, right, they will kind of block, will actually act on estrogen receptors so that estradiol that's circulating won't be able to act on the pituitary and the hypothalamus quite as well, right? And therefore not really exert a negative feedback loop. And then if you use an aromatase inhibitor, that will reduce the amount of estradiol that can act on the hypothalamus and the pituitary, thereby reducing its effect, its negative inhibition effect. And then finally, you can actually directly inject both FSH and LH. So FSH, an FSH analog would be HMG, which again actually also has some effects on the Leydig cells, so it could be construed an FSH and LH analog. And you can inject HCG, which is an LH analog, and both of those directly act on the Sertoli cells and the Leydig cells. right, to both increase either intratesticular testosterone, if it's acting on the Leydig cell, or increase spermatogenesis directly if it's acting on the Sertoli cell. So let's talk a little bit now about debunking some of the myths that are associated, or the common myths associated with testosterone replacement therapy. So the first myth that people have is that testosterone causes a man's penis to shrink. This is not true. In fact, if anything, testosterone can increase the size and girth of your penis because it increases nitric oxide production, and that tends to increase nitrogen retention, increase blood flow. When you do that, of course, that can lead to harder and thicker erections, and increasing nitric oxide is actually one of the things that Cialis does to give men stronger erections as a phosphodiesterase inhibitor. The second myth is the concept of cycling testosterone. There's no need to really cycle testosterone when your blood testosterone levels are low. So once someone comes to see a TRT physician, typically it's because their natural production of testosterone is low, right? And you want to continue it because if you don't, you want to continue treating it, because if you don't treat it, you'll just go back to this low decreased natural production of test. And so in other words, if you were to get on testosterone or TRT and you had a low level of testosterone naturally, and then you stopped it, your endocrine system, number one, would take a few months to rebalance and finally produce the testosterone levels it was at prior. But at the same time, it would be at a lower level, because remember, we are not in a static process. And the time that you're on TRT, so example, let's make, for example, let's say you started TRT when you were 35 years old, and then you say around 40, you're like, you know what, I think I'm going to stop TRT and see what happens. So you stop it. Yeah, it would take a few months for you to get back to your natural production. However, your set point, your natural set point, would be at a lower level because you'd be older, and the natural aging process would take its toll, and your testosterone production, of course, would be decreased. So it doesn't really make sense to cycle it, because if you take enough to kind of keep you at that appropriate baseline amount, you can get all the benefits of optimum testosterone replacement, and avoid the side effects of drops and these symptoms that are associated with low testosterone: depression, decreased muscle mass, increased adipose tissue, etc., etc. Okay, so what are some of the proactive treatments to make sure that you can maintain fertility on TRT? So the first course of action is to get a baseline evaluation of your semen. This is important because if your sperm production is low at baseline prior to TRT, there's really not a lot we can do, because all we can really do is get it back to where your baseline was, right? There are certain disorders where your sperm production is decreased, or the type of sperm that you produce is inferior in some way. It's not, the motility is decreased, so it's good to get a baseline to evaluate where it's at, right? Then you want to go ahead and talk to your provider before you start about how TRT will affect your fertility and what tools that the clinician has to decrease these risks. Whether or not he or she is familiar with HCG, HMG, SERMs, and aromatase inhibitors, right? And it's important because if you take this proactive approach with the upfront evaluation, along with ongoing and regular follow-up studies for hormones and semen analysis, it's definitely possible to maintain fertility and have a good result. And honestly, it's this evaluation and reevaluation that's the key to optimization, and that will give you the best result. Okay, so that really covers all of our topics for today's webinar on sperm count, shrinking, and fertility. Let's just go ahead and summarize what we covered. So we started our time today talking about the hypothalamic-pituitary-gonadal axis, and we talked about how the negative feedback loop occurs um, with natural testosterone production, and how TRT resembles this and actually produces its own negative feedback loop. We talked about some of the common side effects of TRT, as low sperm count, and how to maintain high intratesticular testosterone and fertility while using TRT. We talked about HCG, HMG, and SERMs as effective medications to maintain fertility when you're on TRT. We mentioned that testosterone does not cause shrinkage of your penis, and once a person starts TRT, it's a good idea to be on it for life due to the body shutting off its natural production of testosterone. And then it's important to seek a physician with a deep working knowledge of both TRT and its impacts on spermatogenesis. It's important to get a baseline evaluation of your semen and be proactive with ongoing and regular follow-up studies for both hormones and semen. And this evaluation and reevaluation is the key to your to optimizing your experience with TRT if you wish to maintain your fertility. Okay, and that's we're at the end of our presentation. Thank you again for attending today's webinar. If you have any questions, don't hesitate to contact us at enroll@startsumma.com, and we look forward to seeing you next time.